Hello, friends. Welcome to this virtual meeting of the Diabetic Foot Society of India. I'm Dr. Tarun Sahni from New Delhi, which is exceedingly cold as of now, and I will be speaking to you about the role of hyperbaric oxygen in diabetic foot ulcers. Uh, it's a pleasure to be in this virtual meeting, and during this particular lecture, I will try and define diabetic feet, define the pathophysiology of diabetic foot ulcers, understand the importance of why this focus on diabetic foot ulcers, familiarize you with key publications from literature, understand what is hyperbaric oxygen, mechanism of action, and how does hyperbaric benefit diabetic foot ulcers. Also, what patients will benefit from hyperbaric oxygen. The introduction, which I'm sure a lot of you are already familiar with, 15 to 25% of people with diabetes will develop a foot ulcer. These wounds are often resistant to healing. Therefore, people with diabetes experience lower limb amputation at about 20 times the rate of people without diabetes. If an ulcer does not heal with standard wound care, other therapeutic interventions are offered, one of which is hyperbaric oxygen treatment. This lesson or presentation will review the role of hyperbaric oxygen in select cases of diabetic foot ulcers. The definition of diabetic foot is well known to the audience here. Diabetic foot is one of the most significant and devastating complications of diabetes and is defined as a foot affected by ulceration that is associated with neuropathy and or peripheral arterial disease in the lower limb in a patient with diabetes. It is a long-term or chronic complication of diabetes, and around half of the patients with the diabetic foot ulcers will have a coexisting peripheral artery disease. The pathophysiology, again, to this august audience, which are already familiar with it, the hyperglycemia leads in diabetic foot ulcers due to the following changes: neuropathic, vascular changes, and immune changes. The neuropathic changes manifest in motor, autonomic, and sensory components of the neuropathic foot. These patients notice foot wounds much later because of a decreased peripheral sensation. Vascular changes in the peripheral arteries of the foot results in vasoconstriction and plasma hypercoagulation, leading to ischemia and increased risk of infection. Immune changes include reduced healing responses, increased T lymphocyte apoptosis, which inhibits healing, have been observed in patients with diabetic foot ulcers. This is a diagrammatic presentation of the same thing. The etiology of diabetic foot is due to ischemia, neuropathy, and infection, and it's a combination of this which leads to a seven-fold higher risk of ulceration in diabetic foot patients. Again, a similar chart showing the autonomic changes which take place, and you can have in diabetic foot a hot and turgid foot, you can have an insensible and deformed foot, or you could have a cold and pale feet. Eventually, there is ulceration, infection, or gangrene and infection. And from being a pure neuropathic foot, it can become a neuroischemic foot. And that is only a matter of time if it is not treated adequately. Diabetes is a huge and growing problem, 80% in the developing countries. So by 2035, the global prevalence of diabetes will be 600 million, and around 80% of these will be people living in developed countries like India. An amputation takes place every 30 seconds somewhere in the world due to diabetes. And what is terrifying is that 85% of these amputations are preventable. Early identification of the at-risk foot and prompt treatment by a skilled multidisciplinary foot care team can salvage many of these limbs. Remember, diabetic amputations significantly in significant numbers are preventable. Why this focus on diabetic feet is because 15% of diabetics will develop a foot ulcer. 85% of amputations are preceded by a diabetic ulcer, and 50% of all lower limb amputations are secondary to diabetic feet. Mortality following amputation increases with the level of amputation and ranges from 50% to 68% at 5 years. So, at 5 years, 50% to 68% of patients with lower limb amputations would have succumbed to the disease. Patients with diabetes and diabetic foot ulcers also have an increase in the overall cause of mortality due to cardiovascular disease. So it is not only the limb, it is an overall increase in the mortality due to cardiovascular diseases. Some of the key publications in diabetic foot ulcers, the landmark paper was this on published in Diabetes Care in 1987, where the authors defined the fact that hyperbaric oxygen in conjunction with a multidisciplinary approach is effective in decreasing major amputations. 2002 August is again a milestone in the use of hyperbaric oxygen in diabetic foot ulcer, because this was the time when US Medicare actually recognized uh, hyperbaric oxygen as a treatment modality for diabetic foot ulcers. They were stringent in the definition, and it had to be type 1 or type 2 diabetes with a wound classified as Wagner's grade 2B or higher, and patient should have failed treatment. Conventional treatment had been given for at least 30 days and the wound had still not healed. These were being reimbursed by Medicare in the US, and this was a landmark event in the use of hyperbaric in diabetic foot ulcers. A lot of publications have then come out, and you'll find a review article every few weeks, months in different journals in different parts of the world. And these are now review articles because the role of hyperbaric is now well accepted globally. Hyperbaric oxygen therapy has a significant role in the healing in diabetic foot ulcers. And the definition is that you have to breathe near 100% oxygen under a pressure exceeding 1.4 times that of the atmosphere. So, hyperbaric is a procedure where two criteria have to be met. You're breathing 100% oxygen, and the pressure at which this oxygen is delivered exceeds 1.4 times that of the atmosphere. This slide explains the physiological basis, and we all know that blood normally carries 19 milliliters of oxygen in combination with the hemoglobin and zero point 0.3 milliliters dissolved in plasma. If a person now breathes 100% oxygen at sea level, oxygen combined with hemoglobin can increase from 19 to 20, and the dissolved oxygen from zero point 0.3 to 1.5 milliliters. During hyperbaric oxygen, the hemoglobin is 100% saturated, and the amount of oxygen carried in solution will increase to 5 to 6 milliliters. So from zero point 0.3 ml to 1.5 ml if you're breathing oxygen at normal pressure, and up to 5 to 6 milliliters if you're breathing it in hyperbaric oxygen. This slide shows the oxygen hemoglobin solubility in plasma. And as the pressure increases, the amount of oxygen which dissolves in plasma increases. And you can see the area in yellow. This is the additional increased oxygen which is in solution. And if you look at the pressure of 2.4, 2.5, or 3 ATA on which we treat, so this entire yellow oxygen content will be delivered, and this causes changes at both the macro and the microcirculatory levels. How is hyperbaric oxygen delivered? There are two types of chambers. One is a monoplace chamber where one patient is treated at a time, and the other is a multiple place chamber where multiple patients could be treated at the same time and treated through a mask or a hood which is delivering oxygen. The room is pressurized with air, and the oxygen delivery mechanism delivers oxygen to each individual. Plasma normally carries 100% oxygen and delivers it across the area of occlusion. The 100% oxygen diffuses from plasma up to 3 times further into the tissues. So, what does hyperbaric oxygen do? It helps the oxygen to travel across even where blood vessels are restricted. This plasma can carry 100% oxygen under pressure, and 100% oxygen under pressure diffuses from the plasma into the tissues, and this helps the process of healing. Oxygen under pressure forces more oxygen into tissues and encourages new blood vessels to be formed. So, neovascular genesis or new blood vessel being formed is an output of the hyperbaric oxygen which is delivered to the tissues. Oxygen, extra oxygen then diffuses into the tissues from these new blood vessels. So first, it helps promote new blood vessels, and obviously these blood vessels can then further carry oxygen into areas where they were deprived and give the beneficial effects of hyperbaric oxygen. Uh, all components of wound healing process con- are enhanced with hyperbaric oxygen. Hyperbaric reduces tissue swelling and shortens the inflammatory path. It increases production of collagen, enhances the growth of new blood vessels, angiogenesis. HBOT also increases production and improves the action of osteoblasts and osteoclasts. Hyperbaric oxygen helps prevent infection, and it also potentiates the use of antibiotics and enhances the antimicrobial effect of antibiotics. The role of hyperbaric oxygen therapy in DFU: hyperbaric significantly reduces swelling, enhances new blood vessels to be formed, prevents infection, and potentiates the use of antibiotics. All these factors are responsible for the promotion of wound healing in these patients. What is the dose of hyperbaric oxygen? The dose of hyperbaric is defined in atmospheric pressure absolute. 1 ATA, or atmospheric pressure absolute, is a measure of pressure and is equivalent to 33 feet or 10 meters of water. So a diver who's at 10 meters and which is 33 feet is the measurement or the unit which is used to measure hyperbaric oxygen. So 1 ATA is equivalent to 33 feet or 10 meters or 1 ATA pressure. What is the dose of hyperbaric oxygen? Not greater than 3 ATA and not less than 1.4. Most hyperbaric oxygen treatment is carried out between 1.5 and 2.4 atmospheric pressure absolute. How do you select patients for hyperbaric oxygen in diabetic feet ulcers? Transcutaneous oximetry is a non-invasive test that directly measures the oxygen level of tissue beneath the skin. Because oxygen is carried to tissues by blood flow in the arteries, TCPO2 is an indirect measure of blood flow. This slide shows you how the procedure is performed. This is the transcutaneous oximeter, and these are the electrodes which are placed on the foot, and the readings are looked at from here. Oxygen may also be given to see the patient if we want to demonstrate that giving additional oxygen during hyperbaric will benefit. The oxygen tension normally in the foot ranges to approximately 60 millimeters of mercury. And as this slide shows, if the transcutaneous oximeter is less than 40 millimeters, spontaneous or is greater than 40 meters, spontaneous healing will take place. If it is less than 40, in-chamber transcutaneous oximeter to predict benefit from hyperbaric oxygen therapy should be done. Without comorbidities, wounds are thought to heal in 40 millimeters, and diabetic foot ulcers with an oxygen tension of less than 40 millimeters are suitable for hyperbaric oxygen. This again is a transcutaneous algorithm. So, if you look at correction of hypoxia and transcutaneous oximeter measurement, you can have severe, moderate, or normal oxygenation. You can then do a 100% oxygen challenge to see if it's going to benefit from it or not. And based on it, you can actually uh, indicate which patients should be given hyperbaric oxygen and which should not be given hyperbaric oxygen. So it's a very objective method by which we can assess it. The classification of Wagner's grading system for diabetic foot is one of the oldest classifications and still very popular. All diabetic wounds in lower extremity classified as Wagner's grade 2B or higher should be given hyperbaric oxygen. The dose and duration of hyperbaric oxygen, because it takes approximately 1 hour to saturate the tissues, most treatments have been arbitrarily set at 90 minutes of oxygen. So it takes about 60 to 90 minutes for all the tissues to get endorsed with, uh, to get infiltrated with additional oxygen. And for chronic wounds, repeat hyperbaric procedure once daily for 40 to 60 days could be required for complete healing to take place. Most diabetic wounds require an average of 30 treatments but may need up to 100, and treatment can be continued until the achievement of 100% granulation is seen in the wound bed. Side effects: it's a safe therapy and most side effects are minor in nature. Pain in the ear, like what happens sometimes when you are traveling by air and your eustachian tube is blocked, is one of the commonest reasons of side effects. Pulmonary barotromas and oxygen toxicity seizures are very rare and barely seen in practice. Hypoglycemia can be seen in diabetic patients and easily prevented by proper counseling of patients to take their regular diet and meal before coming in for hyperbaric. Transient myopia, fatigue, headache can be seen in a few, but is completely reversible. And claustrophobia is a risk, but usually in a multiplex chamber, this is not seen. The only absolute contraindication is an untreated pneumothorax. And out of the relative contraindications, you have COPD, asthma, uncontrolled seizures, very high fevers, and some therapeutic chemotherapeutic agents such as cisplatin, doxorubicin, bleomycin, and disulfiram. The cost impact of hyperbaric oxygen. Uh, what you're seeing is the cost, which is the tip of the iceberg. There's a lot of nurse time, hospitalization time, and these collectively lead to a huge cost burden. Ability of hyperbaric to preserve a functional extremity can reduce the high cost of disability resulting from amputation. Shortened healing time for chronic wounds reduces the cost of frequent repeated surgical procedures. So addition of hyperbaric will have a direct impact on cost, and it will reduce the overall cost of treatment and repeated surgical procedures and actually be able to permit the individual to get back to his work at the earliest. In summary, diabetic foot ulcers can be complex and extremely difficult to heal. These patients have a high rate of amputation and overall cause mortality. Hyperbaric is the use of 100% oxygen under pressure in a specialized equipment called hyperbaric oxygen chambers. This increased dissolved oxygen at a higher pressure gradient is responsible for its beneficial effects. Hyperbaric oxygen is indicated in diabetic foot ulcers in Wagner's grade 2B and greater, and those that have not healed in 4 weeks' time with standard treatment techniques. Transcutaneous oximeter is used to assess which wounds will benefit from hyperbaric, and hyperbaric oxygen therapy has been shown to aid healing of diabetic foot ulcers by increasing vascularity, by enhancing immunity, potentiating the effects of antibiotics, and wound healing by promoting collagen formation. The use of hyperbaric as an adjunct treatment for diabetic foot ulcers is evidence based with significant guidelines on when to start and when to stop. Thank you very much, and I hope I have been able to communicate in clarity the role of hyperbaric oxygen therapy in diabetic foot ulcers. All the best for the rest of the meeting, and do reach out to us if you have any further queries. Thank you.